Hello, everyone. My name is Gwon from Samsung Medical Center. And our title is Outcomes of Highly Urgent ABO Incompatible Living Donor Liver Transplantation in National Databases. First of all, in highly urgent cases, an ABO compatible donor may not be available. ABO incompatible LDLT is sometimes the only option, but it raises concerns the infection and rejection. However, there has been very limited evidence on the safety of ABO incompatible LDLT, specifically in the highly urgent setting. Our study has three purposes. First, to compare the outcomes of between ABO incompatible and compatible cases. Second, to identify the risk factors for mortality and graft failure. Last, to the test whether ABO incompatibility independently affects prognosis. This study was a retrospective cohort study using KONOS, Korean national data from 2017 to 2021. We analyzed 363 adult, highly urgent LDLT patients. Among them, 9% was ABO incompatible cases. Pediatric cases were excluded, and the outcome was compared between ABO compatible and ABO incompatible groups. In baseline characteristics of recipient, both demographics and liver disease etiology were similar. However, retransplantation was more frequent in ABO-I group, and MELT above 30 was less common. The waiting time was also slightly longer in ABO incompatible cases. Other severity markers such as ICU admission and ventilator use where CRRT were not significantly different. In donor characteristics, interestingly, minimal invasive surgery, especially robotic surgery, was much more frequent in ABO incompatible groups. Probably it comes from that highly urgent ABO incompatible cases normally did from big center. Complication rates were slightly higher in ABO-I cases, but the severe complications over severe grade 3 occurred only in the ABO compatible cases. There was no donor mortality in both groups. In terms of recipient outcomes, the median follow-up duration was 2 to 3 years. In hospital mortality and infections were similar between two groups. Graft failure was higher in ABO-I cases, but overall survival curves were comparable, though AMR was observed. As I mentioned, the overall survival was comparable between two groups. Graft survival was higher in ABO compatible cases. In multivariable analysis, as you see this table, mortality was strongly associated with CKD and ventilator use and retransplantation and MELT score. Graft failure was predicted by hepatorenal syndrome. The crucial thing was ABO incompatibility itself was not an independent risk factor. In conclusion, the highly urgent LDLT achieves acceptable survival in critical ill patients. ABO incompatible outcomes were comparable to ABO compatible cases. Instead of that, the patient conditions such as the kidney disease and ventilator use and MELT score was more important than ABO compatibility. Therefore, the ABO incompatible is a valid rescue option when no comparable donor is available in highly urgent LDLT. However, our study has few limitations. First, it was retrospective and lacked details about the immunologic or surgical data. And also, the information on pre- and post-desensitization protocols was not available in the national data, which could have influenced our outcomes. Last, the ABO incompatible sample size was smaller than the compatible size. And mainly it comes from from high volume center. So it limited the generalization. Yeah, thank you for your attention and any question.